Namaste. It's 6:30 a.m. in LA and Vancouver, 9:30 a.m. in New York. Good morning to our colleagues in North America. It's 2:30 p.m. in London, 3:30 p.m. in Europe. Good afternoon to friends in Europe. It's 7 p.m. in India, 9:30 p.m. in Singapore, Malaysia. Good evening to our colleagues in Asia, and in Australia, it's 11:30 p.m. past bedtime. A warm welcome to all our colleagues. I'm Anupam Sibal. I'm the president of GAPIO. I'm a pediatric gastroenterologist, and I'm the group medical director of the Apollo Hospitals Group. For those who might be joining for the first time, the Global Indian Physicians COVID-19 Collaborative was established on 11th April to bring together 1.4 million physicians of Indian origin across the globe on one platform. GAPIO now has members from 49 countries. We are looking forward to making it 50 in the coming 2 weeks. It is day 257 since the first case of COVID-19 was diagnosed. COVID-19, as we know, has been reported for more than 200 countries and territories. As of this afternoon, 28.6 million cases, and sadly, more than 920,000 deaths. And in India, we have 4.66 million cases reported with 77,000 plus deaths. An explosion of knowledge like never before has taken place. And just to give you a sense of the knowledge explosion, there are 53,298 papers published on PubMed on COVID-19. That is a staggering 208 papers per day, which amounts to 8.5 papers per hour. When I first started tracking this, there used to be about 5 to 7 papers published a day. Now it's 8.5 papers every hour. And India has made a significant contribution with 3,039 papers on COVID that are visible on PubMed. Today, we'll be discussing recent advances in the management of COVID-19. We have a distinguished group of experts from across the globe. And let's start off by inviting my dear friend, Dr. Anupama Gotikmugala, to give her opening remarks. Anupama is a pediatric anesthetist and works at the Children's Hospital of San Antonio in Texas. And she's the president-elect of API 2122. Over to you, Anupama.
Thank you, Anupam, for the kind introduction, and good morning to all our colleagues from west to east, and welcome to the webinar. And we all know that it's been 6 months already that we are being into this pandemic now, and we are seeing the changes, how the disease is evolving. Like initially we had issues with PPE, lack of PPE, and then we have medications going on now, and now we are crying for vaccine. So unfortunately, the death rates still climbing up as the season is coming down, winter time. Now we expect another rise in the cases. So as of now, as we follow the Johns Hopkins COVID Resource Center data, we calculate the death rates per 100,000. So US has seen 58.6 per 100,000 deaths now, right now. Currently, India is at 5.64, UK 62.7, and the other countries, New Zealand, Singapore, Malaysia, they have a death rate of 0.4 per 100,000. And very interesting thing I was watching today morning was Canada. In the last 24 hours, they had 0 deaths. So I think we are doing well in terms of how to control the pandemic, but there is a lot to learn about it. And millions of tests are being done now, so we are not short of testing now, and including the saliva test, which is the newest of all, which can give you the result in few minutes to less than 1 hour. And no disease in the history has seen so much of research in developments in diagnostics, therapeutics, and vaccine. So 180 vaccines are in development right now. And according to WHO, 35 vaccines are on human trials right now. So hopefully we will get some answer before the end of this year. We will get a safe vaccine. So they are seeing some complications with the vaccine, neurological complications. they are scrutinizing and they are going through depth of these trials. They don't want any vaccine to come out without safety precautions. So I was listening to the audio of WHO press release on September 10th from Soumya Swaminathan. I was hearing to her the complications going on with the vaccine now. So that was interesting. And thank you so much, Anupam, for these webinars, which are giving lots of information to our physicians, educating ourselves, at the same time learning and implementing and all. And thanks to all the speakers today, Dr. Sonal Pannu, Dr. Sanjay Agarwal, Dr. Sushmita Rai Chowdhury, Dr. Ilan Kumaran Paramasivan, Dr. Ravi Mehta, and thanks for all of you for giving your time today. And let's listen to all our colleagues and get some updates today. And let's go back, Anupam. Let's start the session. Thank you.
Thank you so much, Anupama, for your opening remarks. The purpose really is to get some take-home messages from the experts who have hands-on experience, have been part of trials and actually treating patients, because there's just so many questions about remdesivir, about plasma, about steroids, about IL-6 blockers and monoclonal antibodies. And like you said, Anupama, India now is producing about 550,000 PPEs per day, and we are doing 1.1 million tests every day. So clearly from zero tests and virtually no N95s and very limited amount of PPEs, we're the second largest manufacturer of PPEs in the world and actually now exporting. So we move on to my dear colleague, esteemed colleague, Dr. Sudhakar. Dr. Sudhakar is the current president of the American Association of Physicians of Indian Origin, API. Sudhakar is American board certified in internal medicine, gastroenterology, and works as a gastroenterologist and a transplant hepatologist in Georgia. Over to you, Sudhakar.
It's my distinct honor to introduce Dr. Sonal Pannu. Dr. Pannu is currently assistant professor of medicine at Ohio State University Medical Center. She's the president of the Society of the Critical Care Medicine Ohio chapter, and she received multiple awards for clinical research and is a National Institute of Health funded investigator. Dr. Pannu is deeply involved in the COVID-19 care and is co-chair of the COVID-19 inpatient clinical trials task force. She has been leading the expanded access convalescent plasma program at Ohio State University, and she's an investigator for the national clinical trial for convalescent plasma, getting up to enroll 1,000 patients. I'm sure I know very well that she's the first physician to use plasma therapy in the state of Ohio. I know the patient too. Welcome, Dr. Sonal. She's going to talk on plasma therapy.
Thank you, Dr. Sudhakar. That was a very generous introduction. I'm going to share my screen now so we can see my slides. So we're talking about convalescent plasma in the use for COVID-19. Convalescent plasma, as you know, is derived from individuals who are getting better from COVID-19 and had direct antiviral effects from the viral neutralizing antibodies. Also, it's supposed to, it may have indirect effects for anti-inflammatory purposes and also improvement in some organ support and mortality. And we've seen modest effects in the viral epidemics, SARS-CoV, MERS, Ebola, etc. It's fairly inexpensive. We know it's a simplistic therapy. We have years of experience in getting plasma. And, as people get better, the supplies get better. So which plasma should be given and when should it be given? Much of the points that I'm going to discuss today come from the expanded access program. 80,000 patients have been transfused plasma between April and now for COVID-19. And plasma is now an emergency use authorization in the United States. 47,000 patients were analyzed when some of the data was looked for safety and preliminary efficacy. At Ohio State, we have transfused close to 300 patients. So some of my experience comes from that as well. So high titer plasma does show the most benefit. And there's different ways of measuring plasma. And since we're on a worldwide forum, there may be different ways where people are measuring the plasma form. But a neutralizing antibody titer of greater than 1:250 was recommended and has shown some benefit of mortality at 30 days in the EAP data. We've been using initially, since there was more plasma, but there were no studies to test it, we've been using titers of 1:160 and higher. Those were IgG local titers, and those were then correlated to neutralizing antibodies from pseudoviruses or live viruses, and then has shown good correlation. We have used titers as high as 1:600 and 1:10,000, and you see good results. So, while we can't generalize it to all patients, there have been patients where we've seen some, I would say, almost miraculous recoveries. Plasma with that data again says most useful if it's given within 3 days of diagnosis. At sometimes that can be difficult because we don't get patients as early. Some people don't even manifest symptoms that early. Benefits decline by every week when we're looking at this large database. But plasma has been given up to 25 days. I don't feel that when you're that far in the illness that has been that helpful, but I think our best window is to catch before the cytokine surge and the inflammatory phase of ARDS kick in, because after that you're dealing with a lot of the anti-inflammatory effects and not as much as the antiviral effects. And while patients' own antibodies are formed from 10 days onwards, their IgM and IgG, if we want to do a passive immunity transfer, it's better to do it therefore in the first 10 days. So in general, I would prefer it in, I do it in the first week, at the most in the first 2 weeks, but after that, probably not is what I would advise. In the trials that we're recruiting, we wouldn't do more than 14 days after initiation of symptoms. Who should be given and how much plasma would we do? So, as many of the things that we've seen, younger patients benefit more. Less benefit after 80 years, but I guess as patient gets older, the reasons for doing worse are more from comorbid status than, actual treatment. If plasma is a scarce resource, and you want to use it for selective classes of patients, I think they benefit most in patients with hematological disease, active malignancies, especially with NHL, CML, or lymphomas who cannot, actually form their antibodies and are delayed forming antibodies. We had some patients who had less symptoms, but they had disease for weeks and weeks together who had CML. And they did not form antibodies. So at that point, we used to check if they have antibodies. If it's negative, we give them plasma, and you could see some improvement. We've given it to pregnant patients too. Since we've given them pretty early in the disease, I think we had seen some benefits there. We usually give 1 to 2 units. That's what was recommended. That's what's going to be used in the trials. If you have a high titer plasma, even 1 unit should be good. But we've done 2 units. Unless there's a risk of fluid overload for the patient, we give 2 units back to back. There's been experience of doing 2 units at 24 hours if you're concerned, or at 48 hours, but there's probably no benefit of doing it at more than 48 hours. At many studies, they are looking at doing, recurrent units of plasma, 3-4 units, to see that there has been benefit. But at the best, the most experience in the world is for 2 units to be either given right away or at 24 hours notice. The 24-hour difference is usually if you're seeing some kind of side effects that I'll talk about soon. If you have a local antibody test available, you can always titrate to seropositivity if somebody is not feeling better, not doing better, and you think this is the only treatment that you have. What should you look for when you're giving plasma? I think the most important side effect that I have seen, which is not really reported in studies, is antibody-mediated enhancement. These are the patients who have not been intubated and who are at the cusp, or who are having high oxygen requirements. And occasionally you see antibody-mediated enhancement because of the severe anti-inflammatory response that comes because of neutralizing antibodies, similar to what you see in dengue. Or here in the US, we see a lot of pneumocystis pneumonia that does the same thing. If that happens, plan to support the patient for 12 to 36 hours. And we've seen generally in 1 or 2 days, the patient stabilizes much better. But now with regular use of dexamethasone, we've seen that much, much lesser. Usually if that happened before, we would give the patient dexamethasone, and much earlier in the course of disease, we've even done tocilizumab, and that has helped. Transfusion reactions, which are just allergic, non-hemolytic reactions, pretty less, but you've seen it very occasionally. Anaphylaxis, very rare. Thromboembolic reactions, very rare. Even fluid overload, very rare. So in summary, I would say with all the other treatment that we have, high titer plasma may benefit if given earlier in the disease. If you have a scarce resource and you're not able to get as much as donor plasma, then we can select it for patients who cannot form antibodies. We've seen overall survival in a selected cohort who has got plasma, but we've not actually tested it for many people who have not got plasma and who've got plasma. There are many trials that have already been completed in Spain and China. They have shown trends towards benefit. Some small trials have shown benefit as well. I personally believe that if we pick the right patient and give them high titer plasma, it does help, but it doesn't generalize to everybody. Currently, there are 74 convalescent plasma trials going on in the world to identify the actual mortality benefit. I've seen a very well-designed trial going on in Delhi too, but I don't know what the results of that trial are. And our trial is the Pass It On trial. It's a national trial funded by NIH in the United States. It started recruiting already. We're up to around 50 to 100 patients, and we're looking for 1,000 patients to be completed before the end of the year. Thank you, and I'll be open for any questions.
Thank you. Thank you so much, Sudhakar. Thank you so much, Sonal. I'm really proud to have you on this platform. A decision that we all made a few weeks ago that we were going to get young physicians, young doctors of Indian origin from across the globe to come on and use this platform. So we're really delighted to have someone as young and dynamic as you. There's some Indian data also that has clearly shown that if you tend to give it later, there isn't that much benefit. And that Dutch study that had to be discontinued because they found that everybody they were giving plasma actually already had antibodies. So we're going to have a lot of questions unanswered, and perhaps we will move to outpatient plasma therapy in a selected group of individuals. We're going to come to questions in the end, but we will move on now to the next session. And it is a privilege for me to introduce Dr. Nandkumar Jairam. Dr. Nandkumar Jairam is the Chairman, CEO, and Medical Director of Columbia Asia Group of Hospitals. He's been President of the NABH, numerous important positions in healthcare in India, and is currently the Vice President of CAPIO. Over to you, Dr. Nandkumar.
Thank you, Anupam. It's a pleasure for me to introduce Dr. Sanjay Agarwal, the next speaker, who's an experienced and accomplished board-certified critical care specialist, an interventional pulmonologist and sleep therapist and specialist practicing in San Francisco, and currently an active frontline warrior at the ICU of the Kaiser Group of Hospitals. He has firsthand experience of using remdesivir in SARS, COVID-infected patients, as well as in other treatments that have matured from nascent stages to much more defined approaches now. He's been taking care of patients with the coronavirus infections, the wards, at the local hospitals, as well as in office settings. Dr. Sanjay.
Hi there. Good morning, everybody. To all the organizers, to all the speakers and the elite listeners all over the world. Good morning. Greetings from the US. I'll share my screen here, and thank you for being in the front line that is out of the need. We're going to talk about remdesivir today, the recent advances in management of SARS-CoV-2 as we talked about. So let's talk about the basics first. Let me get this out of the way. Remdesivir is a prodrug of adenosine nucleotide with broad spectrum antiviral activity both in vitro and in animal models against coronavirus family pathogens such as MERS and SARS. It's also been used in Ebola virus in the past. Its active form called remdesivir triphosphate is incorporated into the SARS-CoV RNA chain via the RDRP, the polymerase, which leading to delayed chain termination and killing of the virus. It's shown activity against SARS-CoV-2 in vitro in the Vero E6 line of cells, as well as clinical improvement in rhesus macaques. But RDV is still considered as an investigational agent. So what evidence do we have? In mid-March 17, COVID patients received remdesivir and Diamond Princess cruises in Japan for 10 days, and all patients are still alive, and more than half of them have recovered. In April, Gilead said that 53 patients who received remdesivir under compassionate use program showed a clinical improvement of 84% after 28 days of follow-up. A study by the National Institute of Allergy and Infectious Disease showed remdesivir sped up the time to recovery by 31% versus placebo, 11 versus 15 days, p-value of less than 0.001, and also a positive trend for survival, with mortality rate of 8% in remdesivir group versus 11.6%. This was in ACTT trial by National Institute of Allergy and Infectious Disease. In another study, Gilead tested 5 days versus 10 days regimen of remdesivir in severely ill patients. So this is a category for severely ill, and the drug showed a similar outcome in both group of patients. Continuing further on summary, on June 1st, Gilead released the early results of phase 3 trial from SIMPLE2 trial, phase 3 data, and it showed this was for moderate COVID-19 patients. Patients who received the 5 days remdesivir plus standard of care had a 65% better chance of improvement versus those in only the standard of care arm. But the 10 days course did not show any statistical significance. So from this data, as we know that all the protocols and all about the hospitals, every place in all the countries, they have been constantly modifying their remdesivir protocols, and hence the 5-day protocol is now more accepted even for severe or moderate patients. In July, Gilead released the early release of ongoing large trial that remdesivir cuts down on the risk of death by 62%. So Gilead now has several studies showing a benefit for remdesivir in coronavirus treatment. They proposed also, apart from the IV form, it proposed an inhaled version of remdesivir, and it's also trying on different combination regimens along with anti-inflammatory drugs with the IV forms to prevent the overwhelming response. In fact, right now, the ACTT number 3 randomized controlled trial by National Institute of Allergy and Infectious Disease is currently testing the safety and efficacy of remdesivir in combination with the immunomodulator interferon beta-1 alpha in the hospitalized COVID-19 patients. So where are we with the FDA? So remdesivir actually was given, based on the initial data in March and April, was given the emergency use authorization for remdesivir in coronavirus. And subsequently, it also gained a conditional marketing authorization in Europe and is now fully approved in Japan. On August 10th, based on the last 6 months of numerous studies, Gilead officially filed a new drug application to the FDA for remdesivir, with the brand name of called Veklury, as a treatment for COVID-19. So not anymore EUS, but EUA or emergency use authorization, but as treatment itself. This will open the drug for sale once the EUA ends, whenever that might be. So Gilead proposed to sell the remdesivir for a price of approximately $2,340 per patient. That is a 5 days course, and this is for government entities, but of course will be paid slightly higher by commercial insurance at $3,120. And on August 28th, based on further data coming in from JAMA Network towards the end of August, FDA broadened the emergency use authorization for remdesivir to include all hospitalized patients, not just severe, not just moderate, but for any group of patients who have been admitted to the hospital. So the shortage of remdesivir prevails because you cannot manufacture much. It's a hard process. It's worldwide shortage. Remdesivir has been manufactured in the subcontinent, given the license by Gilead for about 5 different companies. Three of them are in India. European Union had a hard time buying just 30,000 COVID patient medicines, and that was about in July 30th. The news we heard about. Taiwan had a hard time laying their hands on remdesivir after the US bought nearly all global supplies, and they provisionally approved dexamethasone as a COVID treatment first line of choice. And Pfizer signed up a multi-year agreement just about a month ago to make remdesivir for Gilead, which is under pressure to increase the supplies. Let's talk a little bit about remdesivir itself. It's a busy slide, but I'm going to break it for you line by line. So the packaging, dosing, and duration. In this section, we talk about remdesivir is available as lyophilized powder and a concentrated solution. The lyophilized powder can be used both for patients who are adults and also for kids, but the concentrated solution should be used only for adults. The dosing appropriate is still not known, we have been using the same dose of 200 milligrams in the day one and then 100 milligrams subsequently after. Since the first day, even in Princess Cruise, we talked about, so more than 40 kilograms of patients, we had 200 milligrams of day one and 100 milligrams of daily for 5 or 10 days. For less than 40 kilogram weight, we want to give 5 milligrams per kilogram loading dose on the first day and 2.5 milligram per kilogram subsequently after. The vials don't have any preservatives or bacteriostatic agents. They come in lyophilized powders, so there are strict aseptic techniques have to be used in preparation of the final parenteral solution. And the medication has to be used immediately after preparation, but it can be used for storage up to about 4 hours at room temperature, which is about 20 degrees centigrade to 25 degrees centigrade, and about 24 hours at low refrigeration of 2 degrees to 8 degrees centigrade. Any unused portion of the single vial should be discarded, not to be stored. And the prepared solution in sodium chloride should not be co-administered with any other medication, as we don't know the compatibilities. So what about the patient selection? So as we talked about the most recent recommendation, it can be used at any time for any patient, mild, moderate, or severe, after onset of symptoms in a hospitalized patient. Whether SARS, initially the criteria was the SARS-CoV antigen has to be positive, patient has to have hypoxemia less than 94%, and have some symptoms or also have some chest X-ray findings. We don't have to have all these criteria anymore. Empiric treatment of hospitalized patients with suspected, it's not confirmed. Even suspected COVID-19 can be considered, and pending confirmation of SARS-CoV-2 infection. All patients must have the estimated glomerular filtration rate measured, determined before you initiate therapy, and also monitoring it daily after receiving while receiving the remdesivir. It has to be measured daily. And same applies for hepatic functions as well. So patients with known hypersensitivity to any ingredient with remdesivir should not receive Veklury at all. These are the 3 criteria which I have to follow. Remdesivir can be used in pregnancy only if the potential benefit justifies the potential risk for the mother and the fetus, because we don't know as to the teratogenicity potential for this drug yet. What about the duration and efficacy? Again, the optimal duration of the medication is still unknown. More and more data is suggesting to limit the use for about 5 days, but it is recommended that for patients requiring invasive positive pressure ventilation or mechanical ventilation, or they are on ECMO, so recommendation is about 10 days, but then again, it is at the discretion of the treating physician. For patients not on IPPV, mechanical ventilation or ECMO, the recommendation is to limit the dosage just about 5 days. But there are certain protocols in different hospitals, different sections in the world, where if there is no clinical improvement is noted, treatment may be extended to up to 10 days, depending on the patient, depending on the treating physician, and the clinical judgment. The clinical efficacy and safety of Veklury is still unclear, and we still don't know as to make those specific recommendations. What to watch for? The 3 main things which you really want to watch for is hypersensitivity, including infusion-related reactions and anaphylaxis, which have been noted in both during and following the administration of remdesivir. In such cases, you want to slow the infusion rate to the maximum rate of just about 120 minutes. The infusion rate is between 30 and 20 minutes of 250 milligrams. Discontinue administration and initiate appropriate treatment for anaphylaxis or infusion-related reactions. Drugs should always be administered in monitor settings by clinical qualified clinicians. It cannot be just given by anybody. There is an increased risk of transaminase elevations and renal failure, and both have been observed in healthy volunteers or in clinical trials. Problem is with transaminase elevations, we don't know if it is because of remdesivir or because of the disease itself. So it can be challenging. So don't want to start remdesivir if the transaminase levels are more than or equal to 5 times the upper limit of normal, which is stage 3 toxicity for liver, or same thing with creatinine more than 1.5 that's stage 3. Before therapy or developed during the therapy, or the ALT elevation with liver inflammation signs, or increased total bilirubin to 2.5 times normal, or alkaline phosphatase, or even INR. And there is a risk of reduced antiviral activity if it is co-administered with hydroxychloroquine or chloroquine, because the data shows the antagonistic effect of chloroquine on intracellular metabolic activation and antiviral activity, the way it acts. Now, clinical responsibility, a decision to continue remdesivir post-adverse event should be made based on the clinical risk and benefit assessment of an individual patient by the treating physician. The treating physician must communicate to patient or the caregiver or any other proxy the information consistent with the fact sheet for patients and parents caregivers, which is available from the FDA website prior to patient receiving remdesivir, and it should be documented in the medical records that the patient or the caregiver has been given the fact sheet for patients and patient caregivers, has been informed of alternatives to receiving Veklury, which there are none, by the way, and informed that remdesivir is an unapproved drug still that is authorized only for emergency use authorization. The healthcare proxy or his designee is also responsible for filling the mandatory responses to the FDA about any adverse event or any medication error or any problems or any serious side effects within 7 days from the onset of the event. So in summary, we reviewed when and how and why, where and what to watch out of the broad spectrum experimental drug remdesivir in SARS-CoV-2 infection and the safety and efficacy based on our published data. Remdesivir is considered now as the mainstay of treatment of SARS-CoV-2, but I want to caution the distinct possibility that all those factors which play along, that remdesivir may never be successfully commercialized, and I'll keep losing my shares value. Thank you so much, and with this I end my talk.
Thank you. Thank you so much, Sanjay. Thank you so much, Dr. Nandkumar, Jairam. Sanjay, that was really helpful, very comprehensive. I think you've clarified very many doubts that a lot of clinicians had. Really appreciate that. We move on to the next talk, and it's a privilege for me to introduce my dear friend, Dr. Sudhir Parekh. Sudhir Bhai is a well-known expert in asthma and allergy in New Jersey. He's also the chairman and publisher of Parekh Worldwide Media and owns ITV Gold channel that most Indian origin folks are familiar with. He has been honored with several awards, the Padam Shri, the Pravasi Bharatiya Samman, the Ellis Island Medal of Honor, and title of the Knights of Malta. Sudhir Bhai.
Thank you. Thank you, Anupam. Good morning, good afternoon, and good evening to everyone, all friends. It's really my privilege to introduce Dr. Sushma Roy Chowdhury. Dr. Susmita Roy Chowdhury is a senior consultant in pulmonology at Apollo Hospital, Kolkata. Dr. Susmita has more than 18 years of experience and specializes in pulmonology, sleep medicine, allergy, and asthma. She is doing research on metabolomics in ILD and airway disease in collaboration with the IIT, and they completed one research paper on that. Dr. Susma was tutor at Glasgow University in UK for 3 years and regularly teaching the DNB trainees. She's also examiner in MRCP and has published more than 30 research papers in various peer review journals. Let's welcome Dr. Susmita ji. Dr. Susmita ji.
Thank you, Dr. Parekh. It's a privilege to be introduced by you with all those kind words. So let me just share my screen. Okay. So my topic has been recent advances in management of COVID-19 monoclonal antibodies. And just a bit of background, we all know that in various viral diseases in the past, neutralizing antibodies have been the key components of protective immunity in most of the viral diseases. In SARS-CoV-2, the identification of the virus itself as the causative organism led to isolation of monoclonal antibodies from the B cells of recovered patients. Now, just to look at the science behind it, what do? The scientists have rapidly identified the pathogen-specific B cells. They recovered immunoglobulin heavy and light chain genes from that, which can be expressed to produce monoclonal antibodies, which is usually in the form of immunoglobulin G. And why is that important? We'll come to that in a minute. The main target of the neutralizing monoclonal antibodies is the surface spike glycoprotein that mediates the viral entry to host cells. So if we just bring it to very simple terms, monoclonal antibodies are just blockers. So the spike proteins of the virus and the ACE2 receptors of the human cell, so that these two don't get together, so that which mediates the virus entry, the monoclonal antibodies simply block the entry. And that's all that they do. Where do we find the clinical utility? So what has been found is they have potential for both prevention and treatment of infection, which was seen early on in Ebola infection. 2 different monoclonal antibody combinations in Ebola infection was shown to be effective in blocking the viral entry. And as a result of that, the devastation that it causes to the body. And several SARS-CoV-2 monoclonal antibodies are in clinical trials presently. We'll just talk about a few of them. So again, if you look at this, the monoclonal antibody, once isolated and injected, it is presumed that in a healthy individual, if it is injected in time, those who are at high risk, it can cause prevention of the virus, again, attaching to the ACE2 receptors, and cause prevention of the disease in the individual. And again, if somebody is already infected with the virus and it is injected into that patient, it will reduce the entry of the viral load into the human cells. As a result of that, there will be milder disease. Those are the presumptions. So it is presumed that in these trials, patients with various degrees of illness will be treated. And because these are IgG products, they have long half-lives, on an average 3 weeks, and hence a single infusion will be required. And it is also presumed that they can work as temporary vaccines, especially in elderly people. If you vaccinate someone, it takes about at least 2 to 3 weeks for the vaccine's potency to be arising in a patient. And in elderly people and those who are immunocompromised, they might not mount a certain amount of antibody response. In those individuals, it is presumed that these monoclonal antibodies in times to come will have a preventive role. So what is the current status? So there are plenty of trials going on, but 2 exciting phase 3 randomized placebo-controlled double-blind trials are ongoing. The first one is Regeneron CoV-2, which is a two monoclonal antibody combinations have been taken, which are designed to bind to 2 points on the SARS-CoV-2 spike protein and prevent entry into the healthy cells. So approximately 2,000 healthy household contacts of COVID patients are being recruited. This is again a prevention as well as a treatment trial, which is ongoing since July. The second one, sponsored by Eli Lilly, is the LiCoV555, which is a single monoclonal antibody isolated from recovered COVID-19 patients. This will assess prevention capability among people at high risk of exposure who either reside or work in skilled nursing or assisted living facilities, and will also evaluate efficacy in allaying or reducing symptoms of a given severity in those who are already infected, and approximately 2,400 people will be randomized. So the good thing about these trials is they require much lesser number of people compared to vaccine trials. The challenges, however, that we foresee in monoclonal antibodies is that there's going to be substantial challenges to demonstrate benefits in clinical trials. Because in severe disease where inflammation and coagulopathy are overt, it may be difficult to demonstrate utility of a monoclonal antibody. Now, choosing the right population for the prevention trials, because in a lot of patients we see that they have mild disease and get better themselves. So whether it was the monoclonal antibody or whether they got better by themselves is going to be difficult to ascertain. Also, there's always a certain risk of vaccine-associated immune-enhanced disease, which may cause...
You've lost your audio, Sushmita.
Can you hear me now?
Yeah.
So vaccine-associated immune-enhanced disease is another worry that we have that we may have to follow. So now let's just talk about a few recombinant monoclonal antibodies that we have come in, we have been using, and tocilizumab is one of them. And a lot of us, including myself, in this panel, have used tocilizumab, which is a humanized recombinant interleukin-6 receptor monoclonal antibody. It has shown mixed outcomes in various studies. In one of the largest trials with results out in July 2020, apart from the Remdaptor trial, the COVACTA trial showed that this molecule did not meet the primary endpoint of improved clinical status of COVID-associated pneumonia or the secondary endpoint of reduced mortality. But it did meet positive trends in times of discharge from when the patient was admitted to hospital. Now, various observation retrospective trials, however, have showed mortality benefit and also time to recover. Including myself, I'm sure the house is going to be divided on whether tocilizumab works or not, but we have found patients who do benefit from tocilizumab. The other one is sarilumab. Sarilumab, rheumatologists know this much better, has been in use for a very long time as a humanized, recombinant humanized anti-IL-6 monoclonal antibodies. It is currently in phase 3 trials, and the endpoints that they're looking at is inflammatory markers, which is C-reactive protein, where it seems to be bringing the inflammatory markers down quite well. And patients progressing onto ventilators is also showing some benefit. But at the moment, I do not have much more evidence apart from that. It has gone from phase 2 to phase 3 trials. Interleukin-1 inhibitor anakinra is another one. Several retrospective studies in moderate to severe ARDS, only moderate to severe ARDS patients who were not on ventilators were put on anakinra, and they looked at improvement of inflammatory markers, improvement in respiratory function, and progression to mechanical ventilation. Not much out there, or I'm not sure if anybody's used it, but not much evidence out there of use for it at the moment. So if I were to conclude, human neutralizing antibodies can block COVID-19 infection. Most monoclonal antibodies inhibit the binding S protein to ACE2 receptors in COVID infection. Monoclonal antibodies represent a major class of biotherapeutics for passive immunotherapy to fight against viral infections, and let's watch the space for them in the future. So they do have preventive and treatment potential in theory, but it'll be left to see how they work. And finally, interleukin-6 inhibitors currently have insufficient evidence regarding clinical efficacy and safety. Their use should be considered experimental and with proper consent in a clinical trial oversight. Thank you very much.
Thank you so much, Sudhir Bhai. Thank you so much, Sushmita. Very well done. And like you said, watch this space. We seem to have moved on from where we were a few weeks ago about IL-6 and where we are today, when we've seen the side effects and the fact that it doesn't really change outcomes. Thank you so much. May I now call upon Dr. Suresh Reddy. Suresh is a well-known interventional radiologist in Chicago. Suresh is the immediate past president of API. Played a huge role in putting this collaborative together. Thanks ever so much, Suresh. Over to you.
Thank you, Anupam. What happened in the last 6 months has been historic, especially in the medical field. Can you all hear me?
Yeah.
Okay, thank you. Thank you, Anupam. And as you know, the whole world changed, the economy changed, the science changed in the last 6 months, and the whole perception of healthcare has changed among the normal people, like laymen. And Anupam and Suresh, we have been coordinating very well, and API and GAPIO have worked so well in this pandemic. When this COVID hit us 6 months ago, we both were at the top of the organizations, and these two organizations have done amazing. So many education programs, almost 300 speakers and almost 100 webinars have been organized by both these organizations. And as far as I know, other than WHO and NIH, these two organizations have imparted so much education to the entire world. I'm very proud of both of these organizations. And this virus is different from what we read in the past. It behaves differently, it smells differently, and unfortunately it has hit several countries, but two most countries that are really dear to us, that's United States and India. Thank you again, Anupam, for giving me this opportunity. Now I will introduce Dr. Ravi Mehta. Dr. Ravi Mehta is an American board certified in pulmonary medicine and is senior consultant, interventional pulmonology at Apollo Hospital, Jayanagar, Bangalore. Dr. Mehta is an established clinician, researcher, and a teacher in the field of pulmonology, critical care, and sleep disorders medicine. Dr. Mehta has extensive academic training and professional experience from USA. I also thank Dr. Tandon for coordinating and executing such an amazing webinar. And Dr. Mehta, it's yours. Thank you.
Yeah, so thank you everybody, and thanks to Anupam, Gapio, and this forum for giving us an opportunity to speak here, albeit as has been pointed out, it's one of the most um, horrible things which has happened, and maybe it's not such a pleasure to take this up in so much detail, but we have no option as we deal with it at its peak in India, especially in Bangalore at this point. So the topic given to me is steroids and COVID-19, demystifying this, and I chose the 6 to 7 minutes, which I think is a very interesting part of this whole teaching paradigm. So rationale for use of steroids in acute COVID-19, well, it came down to the fact that the science moved faster, the clinical events moving faster than the science could catch up. And clearly an inflammatory phase was realized very quickly as the pandemic was moving from China towards the West. The markers came up in a way which we never really fathomed. We have never really measured so much of ferritin and IL-6 in our resistance, validated as being an index of acute inflammation with numbers never seen before. The elevated or increased serally in these markers is something which has become standard of care. And then came the revolutionary finding of the CT scan, which we found difficult to digest, but now easy to implement, and a lot of information where the patterns of inflammation, particularly organizing pneumonia, were laying the credence to a strong inflammatory component over there. And that set the stage for steroids over there. And then came down to the fact that in this viral organizing pneumonia, can we extend steroid use to an infective process, which has traditionally not been that common. And over there, the data came in, and I put these three as being the wise old men who have actually helped us very rapidly, extremely rapidly. I've never seen this in any situation where we've had RCTs coming in to help us guide in a complex situation. So evidence for steroids came from dexamethasone, and those of us who are pulmonologists look upon this with a little askance, as it wasn't one of the common ones we use for the lung. The Codex trial, which was one of the trials which came, then used a certain dose over there, a pretty stiff dose for a period of 10 days. How these doses were figured out, why, and so on and so forth is again a big science by itself. The number of patients reflect the COVID pandemic. The moment you had a certain number, you came out with your data. Here, of course, it was all used for severe patients, and it turned out that this was giving you an advantage of ventilator-free days in a significant fashion, but there was no mortality benefit. But understand that anything which gave a signal towards some improvement was rapidly accepted in the COVID pandemic. And then came the Cornerstone trial, the UK, which took 15% of its patients in the intensive care unit, used a much more modest dose, had a large number of patients because of the tremendous collaborative effort of a scale probably not yet seen in the COVID pandemic, short of the retracted papers, if I may say so. Here, the patients are moderate and severe. So it was also including a larger population besides the mechanically ventilated population. And there was all mortality benefit of 23 versus 26 patients, which was significant. But the subset analysis was even more interesting. Sicker was the patient, more the chances of being on mechanical ventilation, more was the mortality benefit. Secondly, the ones who are on oxygen also benefited, but the ones who basically did not require any respiratory or oxygen support did not have any advantage at all. So when you take all of them and club them together, there was an overall mortality benefit, but the subset analysis lent credence to the fact that sicker your patient, go ahead and do this because it's going to save lives. This is the Codex paper which came over here. You can see the number of authors reflecting the collaborative effort. And of course, the recovery trial, which completely changed the practice patterns to the point that UK within less than 24 hours had a complete pan UK change in practice. As they regretfully admitted that more than 5,000 lives could have been saved if they had used this strategy earlier. Then came trials on other steroids, which are going on simultaneously, but which had to come to a grinding halt, as the recovery trial was the leading one, which reached the line and set the stage for steroids. And here, interesting name, COVID and REMAP-CAB, where steroids were used in various doses, similar to what was used before in shock, which was roughly to the tune of 200 milligrams per day. All of them were showing a trend towards some improvement in mortality. They had different subsets. Some were for mechanical ventilation, some were less sick, and so on and so forth on NIV and HFNC. And we must understand that now NIV was coming back in, HFNC was coming back in, which was not there before. And they were stopped early in view of the recovery trial, but they showed various advantages of reducing ventilation, reduced hospital stay, and organ support-free days. So more and more steroids in different forms were being reinforced. And this was the hydrocortisone trial. And this was the other one, which was also stopped. And all these were published very recently in this month with their findings, definitely indicating the role of steroids in this particular crisis. The WHO very rapidly then conducted a meta-analysis, which also set the stage for reinforcing these findings, where they mentioned the odds ratio for mortality for dexamethasone, hydrocortisone, and methylprednisolone. In the interest of time, I have not gone through all the studies on methylprednisolone, but certainly that also was showing its mark, indicating a class effect. However, it was re-emphasized also that glucocorticoid effect is what is important. Mineralocorticoid effect is not that important. So the original studies being with dexamethasone, easily available and quite economical, that became the standard of care everywhere. And so this was the WHO REACT work, which reinforced the whole paradigm. So what does all this evidence, both indicative, conclusive, and categorical, suggest? Well, there was a clear benefit. Mortality, which was the holy grail of all outcomes in the COVID pandemic, which we were really hunting for desperately. And then, of course, support-free days, length of stay, mechanical ventilation, all the good stuff, which we believe in critical care was also equally important and validated in some trial or the other with some steroid or the other in a reasonably equivalent dose. Timing, this was a very interesting paradigm that if you use it too early, then people are very worried that the viremia is going to get worse, which was the reason for the initial no steroid paradigm, which was put out even by the WHO. If you use it too late, it's not going to be of advantage. So a certain category of patient with an inflammatory phenotype at that particular point is going to benefit with steroids used appropriately. Duration, again, as I said, what, how, when, dose, this was now 5 to 10 days in the trials. And then came the next level of thinking. As we are rapidly, the needle moved towards the post-COVID phase. We can see different parts of the world are in different phases. It came down to the fact that if you control this inflammation early, not only are you getting a life back, but are you also reducing the progression to fibrosis, which I think Anupam may take as another paradigm down the line for a GAPIO forum. It came down to the fact that steroid fears of secondary infection, interestingly, despite 24% diabetics in the recovery trial, were not really validated, and insulin requirement, though mentioned, did not really impact on anything except for increasing the requirements for care over there. Though we have also seen hyperglycemia quite common, the Indian diabetic spectrum being large, on a practical basis, we see that requiring many more insulin drips than before. Which steroid to use was $1 million question. The American trained people like methylprednisolone, the UK guys like hydrocort and dexamethasone. Recovery was done with dexamethasone. It came down to the fact that yes, dexamethasone is the trial drug. However, clearly equivalent doses of methylprednisolone, prednisone, or hydrocortisone can also be used, and often we will shift from one to the other, especially when our patients are going into septic shock and so on, which was also part of the hydrocort trials mentioned earlier. So clearly this was a conclusion which came out of all these rapidly done, well instituted, but parallelly reflective studies. Then, since I have complete steroids to talk about, and I think I have a couple of minutes, inhaled corticosteroids, lovely videos coming from the US saying that I use budesonide and it's working for all my patients. There is some science about it, and provocatively, this has been like the case for the science, but no data. So here, both cyclosinide and budesonide were known to have some sort of impact on SARS-CoV-2 cytopathic activity, and so a lot of hype has come around it, but not validated to the point that it can be applied in clinical practice. One of the most interesting areas we touched on is post-COVID fibrosis and the role of steroids. So just briefly, post-COVID fibrosis usually happens after 2 weeks. This is well talked of in ARDS, and there is nice pathological data also from the NEJM paper. IL-6, the same inflammatory marker which Sushmita mentioned, is also pro-fibrotic. So if you make it out of one, then you'll look left with the other. And of course, the fact is that there's a simile between severe COVID-19 and IPF. And we put down the fact that there is a tragedy that the world may be left with pulmonary cripples because of the volume, and put an interesting phrase that patients go from the cards frying pan, which is the COVID ARDS frying pan, into the post-COVID ARDS fire. It is very, very worrisome. And so the whole thing is that can we do something at an earlier level to prevent fibrosis or slow down fibrosis? And steroids are assuming some important inflammatory, as an inflammatory agent, assuming some role over there, assuming there's some organizing pneumonia, and that's all analytics based on clinical, radiological, and maybe markers to try and see what are we going to use. Nothing, only time, steroids or antifibrotic studies, agents, which is another topic which can be discussed at length. So to summarize this entire role of steroids, moderate to high systemic steroids, note this phrase over here, are a game changer, one of the few game changers to improve mortality in moderate to severe COVID-19. We started off with the ventilated guys, now it's going to anybody on oxygen support. One of the few strategies besides oxygen and left shift of care which can impact on survival. Tangible benefits, as we talked about, is mortality and organ support free days to add the ventilator free time. Duration is 5 to 10 days, variably described. It is indeed a paradigm shift which has been revolutionary from source control, as we know of in these sick illnesses, to downstream consequence control of the anti-inflammatory consequence. And it's a 180-degree shift in a span of 3 months flat, from no steroids to all, which we have been looking at. It's a provocated, unsubstantiated science, which made more its mark in social media than in practice is inhaled steroids. Though we do admit we lean towards giving nebulization with that in patients who can get it. Post-COVID inflammofibrosis, a term we think is interesting. Steroids are uncertain, but certainly commonly prescribed because inflammation treated has a greater role of trying to improve things than trying to either halt or improve fibrosis. And the other internal debate of steroids versus antifibrotic agents is a subject of multiple meetings. Unanswered questions in the steroid paradigm. When do we do this? Clearly, too early is not good. Too late is also not good, can do harm also. So the tendency of people to treat CT scans with normal saturation is to be discouraged. And we leave you with the thought that at best, it's an integrative strategy. If you take an entity which has got a viremic component, an inflammatory component, a thrombotic component, and a multi-system component, it can add a bit, which it has done. So it is it is a valuable part of the multi-pronged strategy against a myriad manifestation disease such as COVID-19. These are multiple references. Anupam, I'll be happy to share this presentation as required. And I thank you very much for the close attention.
Thank you. Thank you so much. Suresh, and thank you so much, Ravi, for demystifying steroids in 7 minutes flat. You are a part of the Apollo COVID core group, and Ram Gopal Krishnan is of course going to lead the Q&A, and you guys have all been working together to create the guidelines. I distinctly remember, and that's why I'm saying this, we've revised our clinical protocol 28 times, and Ram Gopal Krishnan is the one who drafts it, and then it gets ratified. And I distinctly remember when the recovery trial data came out, we had to change our guidelines twice. We had to change them within 12 hours because finally we had something that we are all familiar with, something that is cheap, something that we have a lot of experience with, and something that really showed that it made a difference. Thanks ever so much, Ravi. We now move on to the next session, and to introduce the speaker, we have Dr. Sunny Kurian. Sunny is a very well-known pediatrician in the Middle East. He established the Indian Academy of Pediatrics Emirates chapter. He is the past president of the Association of Kerala Medical Graduates and chairman of Dr. Sunny Healthcare Group in the UAE, based out of Sharjah. Over to you, Sunny.
Thank you, Anupam. And hello to everyone from different parts of the world. Greetings from Sharjah. In these COVID times, I think I want to appreciate the efforts of Anupam, Dr. Tandon and team for getting all of us together. And I find it a great privilege to be in such august company of all, from all over the world, such great scientists. So let's get down to business. It's my privilege to be introducing Dr. Elan Kumaran Paramashivan, who is a consultant pulmonologist and intensive care physician at St. James's University Hospital in Leeds. He is a member of the European Society of Intensive Care Medicine, fellow of the Faculty of Intensive Care Medicine, and fellow of Royal College of Physicians. He is an honorary senior lecturer and postgraduate in Research Institute at Leeds University. He is an executive member of COVID Research Committee at Leeds and principal investigator for the adaptive platform trial for COVID pneumonia called REMAP-CAT, and has led the critical care research team. Over to you, Dr. Paramashivam, and take it off from here. Thank you.
Thank you, Dr. Kurian. I will thank you all for coming and listening to this. I will start my slide sharing. So the topic that I've been given to talk has been the antivirals. And when I started the preparation for this, I was looking at the internet about two weeks ago, and then I looked at it yesterday just to update. And at the moment, when we look at the total number of antivirals that are there, there's something about 32, 33 antivirals that are currently there. When we started the pandemic about 4 months ago, what we started with is none of them were there about a week ago. What we've proven is that what we started initially was pretty much completely gone, and we have a whole new set of antivirals. So the topic that I've been given is to talk in 7 minutes when, what, and why, and what kind of antivirals are we currently thinking. And I'm sure if I do this talk again in a month, many of what I'm talking would probably be different. So I'm going to start the slides initially by giving an introduction about what would be the timing of when would be the ideal time to give an antiviral. I mean, being a viral disease, it makes common sense to think the first thing that you think about is an antiviral. But we know that unlike antibiotics, antivirals are not as effective. One thing that we've learned in this course of the 6 months is the course of the illness. The illness starts off with an initial viremic phase. The viremic phase often is starting with over a period of about a week. 85% of the patients who get an infection we know are mild and they don't necessarily progress. About 15% progress on to the pneumonic phase, and then they develop a multisystem inflammatory process, and about 5% or so end up with critical illness. Now, if we then look at the various parameters to choose, starting from the viral load, the highest viral load the patient has is about a couple of days before they become symptomatic. And then it carries on for the first 4 or 5 days. And then the viral load starts to drip as the inflammation starts to pick up and as the adaptive immunity starts to kick in. So the fact that the innate immunity fails and the virus then produces the inflammatory process then results in the entire process of the illness getting worse. So intuitively, if you were to give an antiviral, the best timing to give the antiviral drug would be at the initial phase in the first week, if possible, when the virus is predominantly replicating in the pulmonary alveoli. And if you can, at some point, stop it at that point, the benefit would be the maximum. If you then give the antiviral later on, I'm sure there will be more benefit, but the proportional benefit will be less. So when and what are the giving the antivirals for and at the various phases of the disease? The first phase, which is the post-exposure prophylactic phase. This would be the most ideal thing. This is where we talk about the vaccines, we talk about potentially hydroxychloroquine, one of the most controversial drugs. And this is predominantly with the purpose that we're preventing the disease. More importantly, the phase that majority of the patients have is this mild to moderate phase. And this forms pretty much about 8 out of 10 patients. Now, they are the most important part of the people who transmit the disease. They don't come into secondary care for any particular illness. In this group, the antivirals will make a big difference in that it reduces the transmission by reducing the viral load. It reduces the duration of symptoms. It can prevent progression of the disease, provided they are effective for it. So the aim of giving an antiviral in this group, even though many of them do get better, is that it does have a very distinct role in the way that they can reduce the burden of the disease. In the last part, once the disease gets established, of course, the aim of the antiviral would be to try and go along with all the rest of the other adjunctive treatments to try and reduce the mortality. So we have a variety of drugs that we have used for certain purposes. And why have these drugs been particularly chosen? Well, the reason why we've chosen these drugs is because the SARS-CoV-2 virus belongs to the family of viruses that include the common cold, the influenza virus, the virus that produced the previous coronavirus pandemics, the SARS and the MERS viruses. And with that, it gets about 80% genomic similarity. So it's a very, very similar virus with small variation. The second most important part is the viral entry, apart from the unique factor of attaching to the ACE receptor, the replication is very similar to other viruses, such as the RNA viruses of HIV and hepatitis. The last bit that makes us to choose these antivirals is because of the in vitro evidence that the previous coronaviruses showed when we had the pandemics in 2003 and 30. So most of the antiviral drugs that we choose are pretty much dependent on these basic facts, and this is why we think they will work in SARS-CoV-2. So if I try to classify these drugs, what are these drugs and what kind of drugs and where do these drugs work? The first part, which is before the entry of the virus into the human cell, well, that's where the chloroquine, the hydroxychloroquine, the interferons, the arbidol, and the antibodies against the spike proteins can be used. I'm not going to talk too much about the chloroquines and hydroxychloroquine. I was originally planning to before the recovery trial was published in middle of June, middle of July, and since then we have stopped using hydroxychloroquine, and I'm told that we don't use hydroxychloroquine in India as well. So the second part, once the virus gets entered into the alveolar cell by the lyophilization, and then it starts replicating, and that is where the crucial part of the intervention happens, because that's the viremic phase. And if you are able to stop the proliferation of the virus at that point, you would have a significant clinical benefit. And among the drugs that we have, remdesivir, which we had a fantastic presentation on, then we have a second drug, the favipiravir, which about a month ago was licensed in India, and it's now been rapidly licensed in about 32 countries around the world. We don't use it in the United Kingdom yet or in USA. Then you have the ribavirin, which is a virus which we used to use a lot in hepatitis C, and we used to use it in RSV infection, so it's had a long safety profile. So this favipiravir and ribavirin are the two drugs that I will be talking about. The next drug is the HIV drug, the retinover lipinover drug, which is a protease inhibitor, which again has been used for a while. And then we have the Tamiflu, the oseltamivir, which is because of its similarity to the flu virus. So these are the variety of antivirals that we have. The top ones, the viral blockers, we know from our randomized controlled trials that there is more harm than benefit, so we don't use it anymore. So I'm going to start off with the first antiviral that I want to talk about today, which is the one that is currently being most interest to many people. And I'm going to concentrate on this because, as I said in the beginning, the biggest impact of the antivirals probably will be in that early phase of the mild to moderate disease. But why is favipiravir? This is the first drug that I'm going to talk about is lopinavir retinover. Now, this drug has been used for HIV for quite a while. It's a proteinase inhibitor. The proteinase is an enzyme that essentially produces a copy of the RNA that gets into the cell, and it results in the polypeptide processing, which the coronavirus is heavily dependent on to proliferate inside an alveolar cell. So the moment you are able to produce a concentration of the lipinover to an extent that is enough inside the alveolar cell, you're able to stop the proliferation of the virus. Now the dose of what we have traditionally used is 400 milligrams of lopinavir and 100 milligrams of retinover. That 100 milligrams is an adjunct that is added to the active component because it prolongs the half-life. It's given twice a day for 14 days. But one of the crucial things with lopinavir is that if we do the minimum inhibitory concentration of this drug in vitro cells after giving a dose of 400 milligrams, the actual micromoles that you get in the cells producing the inhibition of 50% of the coronavirus is actually not very high. So there is a small problem with the efficacy of this dose, but unfortunately, if you go for a higher dose of the drug, it produces a lot more adverse effects with gastrointestinal problems, abnormal liver enzymes, and problems with drug interactions because of the cytochrome P450 inhibition. So in a way, the dose is not adequate, but that's where we are. So overall, if you look at the randomized controlled trials that have been done, a few of them done, including the recovery trial that we had in the UK, which lopinavir has been stopped because of the lack of efficacy in severe and moderately severe patients. It hasn't been tried in mild patients, or at least I can't see many randomized controlled trials in mild patients. But if you were to give it, you need to have a very good safety profile and minimal adverse effects in this group. And as a result, it is not a very favored drug. And so it's more in moderate and severe illness and it is not something that we are likely to show any promising in the future. The next drug, the favipiravir. Now, this is fast becoming a very favored drug in the mild moderate category. Now, why? Now, this is a drug that was originally developed in Japan. It's a synthetic drug. It's a prodrug. And once it gets into the cell, it then gets ribosylized, and then it then mimics the substrate. It mimics like a substrate for the RNA-dependent RNA polymerase, which is the enzyme that actually will help the coronavirus to replicate. And as a result, it permanently inhibits the replication. The drug was licensed in Japan in 2013. The drug wasn't actually used, but it was kept as a reserve drug in the event of an influenza pandemic. And it was thought to be one of the best drugs because of its effectiveness in inhibiting viral replication and reducing the viral shedding. So there were several studies that showed that it considerably reduced the viral shedding load. And the dose of favipiravir that has been commonly advised, this comes as either 200 milligram tablets, and I think it is currently being formulated as 400 milligram tablets. And the dose that is currently used is about 1,800 milligrams twice a day, and that would be about 9 tablets twice a day, followed by 800 milligrams twice a day for up to 14 days. Now, this dose, even though it is what is currently used, we don't know whether that dose would be enough to produce the viral shedding we're looking for. There's a trial that has been published from India, and that was published only on September 2nd, and this was published looking at 50 patients in either arm, giving a higher dose of favipiravir at 3,600 milligrams a day, and then 1,600 milligrams for 14 days in mild to moderate patients after the onset of fever. And this reduced the duration of symptoms from 7 days to 4 days. And by 4th day, the viral swabs were negative. The amount of side effects on that study that was published, it wasn't fully published, but the results were written up in a paper that was published on the 2nd of September. And they showed the most common side effect you get is hyperuricemia and diarrhea. And that happens in about 5% of the patients. Majority of them don't have problems with it. The second one is the decrease in the neutrophil count and some amount of liver abnormalities. But none of them were serious enough to stop the drug. So broadly speaking, an oral drug, a drug that's been there for 7 years, and a drug that can be used as an outpatient, and a drug that can reduce the viral shedding. So it's a very promising drug in the mild category. The next drug that we have is a drug called ribavirin. Now this drug, this has been again a prodrug. It then gets metabolized. It resembles the purine RNA nucleotides. It interferes with the RNA metabolism. Again, it reduces the viral replication. It's given variably depending on a clinical trial basis, which trial you look for. The dose that is generally given is about 4 grams orally as a loading dose to be delivered followed by 1.2 grams orally every 8 hours, or 500 milligrams given intravenously twice a day or 3 times a day. Again, the minimum inhibitory concentration you need to achieve with ribavirin is that it is an intravenous dose gives a better MIC compared to the oral dose. Again, the studies that they've used it, there's one study that is published 2 weeks ago where ribavirin is used as a monotherapy without any other drugs in mild to moderate illness, and that did not show any big benefit. So as a monotherapy, ribavirin is currently not it's not a licensed drug, and it is not that effective in a randomized controlled trial. But it is being used in combination because of its novelty of action on the immune system, because it is supposed to augment the effects of interferons, and it improves the sensitivity of the other antivirals. So it has a very synergistic effect with the other drugs. So if there is going to be a role for ribavirin, it's going to be in a combination therapy. The most common side effect that we look for is in hemolytic anemia. So it does mandate that if you're using ribavirin, you would need to be careful about the drop in hemoglobin and things. But again, hemolytic anemia by itself doesn't make you to stop the drug. Now this drug is yet to find its place. So moving on to the last one, which is the combination therapy. Now, this is the paper that was published about a month ago, looking at the combination of interferon beta along with ribavirin. And this combination is given, as I said, the reason why it has been chosen is because
Please unmute yourself, Ellen Kumar. You muted yourself.
Oh, did I? Okay. Is it unmuted now?
Yeah, yeah.
Oh, okay. Well, I'm nearly there. So ribavirin augments and synergistically acts along with the interferons. The combination of the lipinol 400 milligrams along with retinol 100 milligrams twice a day, ribavirin 400 milligrams every 12 hourly twice a day. Again, 3 doses of 8 million international units of interferon beta 1b on alternate days for 14 days. This is what was tried. Now, this is a Hong Kong trial, and this included roughly about 120 patients between the months of March and April. And this included a variety of patients from mild illness to moderate illness requiring oxygen to those requiring non-invasive ventilation. And what they showed was the benefit of this combination was best in those patients who required oxygen and not a non-invasive ventilation. So again, this is a combination that could be tried in mild to moderate illness. But none of this, this particular paper didn't show any major benefit in terms of number of people it prevented from progressing to invasive ventilation. So yes, there will be a group of people who will be improved on this, but it's fine. It's again, the place has to be defined with a better RCT. I don't have any more to say because at the moment, as I said, this is for today, and I'm sure there will be another group of drugs in about a month's time. Thank you very much for giving the opportunity.
So good evening, everybody. So let me just go through these list of questions. We don't have a whole lot of questions today. Let me just see what there is, and then a couple of other questions which I have for the speaker. So the first question we have here is for Dr. Ravi Mehta. The questioner says that there was news of lung transplant. Do you think steroids will eliminate any need for lung transplant? Dr. Ravi?
Yeah, so I think it's a very big link to think that a national strategy, which we barely got as a life-saving strategy, is going to help in a very big cascading down entity like transplant. So the whole thing at this point is that if we can reduce the inflammation and reduce the fibrosis, will we lower the harm to the respiratory system and the fibrosis, which is going to happen later. Nobody knows at this point. My feeling is that working in COVID for a while, the severe fibrotic phenotype, they will not make it out of the ICU and the ventilators very easily. They're going to be stuck for a while. So the current scenario is that I have fibrosis, I'm not able to come off a ventilator, and those are the guys who are looking at being transplanted. So yes, to answer that question, steroids, reducing the number of people who will need transplant, yes, hopefully. Categorically, no, not really. Is it something we depend on? Not really. And I think a multi-pronged strategy would be required down the line to keep people away from transplant.
Okay. So the next question is on, somebody has put a scenario saying we are getting COVID negative patients on RT-PCR and rapid antigen, but CT shows signs of COVID. Should we give antivirals like remdesivir to such patients? Perhaps Dr. Sanjay Agarwal, who spoke on remdesivir, can take that.
Sure. If you have a COVID positive patient, so initially it was only for screening wise till about a couple of weeks ago, only for people who have oxygen level less than 94% has to have symptoms and some extra findings or CT scan findings. Of late, since August 28, it's been expanded to all patients who have symptoms, and early intervention is better. So depending on the availability, depending on the patient gut feeling, I think if the patient is sick enough, I would recommend going on with the remdesivir,
okay,
which is the hallmark therapy.
Okay, so the next question is on plasma. If plasma is scarce, should we allocate them to immune compromised patients? And should we give it to all patients with malignancy or only for those with hematologic malignancy? Dr. Sonal Pannu, perhaps you could take that.
Yes, thank you. It's useful for all patients who are immunocompromised and would have a reduced ability to form immunoglobulins. The hematological subset it helps a little bit more in these patients even late in the disease, and even if they have less symptoms, because it really helps elevate and form antibodies for them. So yes, for all cancer, yes, for hematologically even later in disease.
Okay. Next question is on hydroxychloroquine prophylaxis for household contacts and healthcare workers. Has a consensus been reached on its efficacy? Dr. Paramasivan, do you want to answer that?
Well, the randomized controlled trial that was published about a month ago in the New England Journal of Medicine essentially said that if you give it within 4 days, hydroxychloroquine given as 400 milligrams twice a day, and given for a minimum of 4 weeks, the likelihood, which there is an expected 10 to 15% likelihood of household getting a contact, there wasn't a much benefit in preventing an infection within households. But the ICMR has recommended the use of hydroxychloroquine 400 milligrams once a day for a 7-week period for the household contacts. But the actual randomized controlled trial from Canada Minnesota doesn't show any evidence.
Okay, I have a couple of questions which any on the panel can answer. The question is, one person is seeing a large number of patients with pneumothorax in intubated patients, which may be due to barotrauma. But what about in patients who are not intubated? Can we attribute this pneumothorax to COVID per se? And secondly, is pneumothorax more common on the right side as opposed to the left side? A question on that. Any of you could take that? Do you want to take a shot, Dr. Ravi? You must be seeing a lot of these patients.
Yes, it's a lovely question, Ram. And I think this barotrauma has been bothering us. And we first realized that when suddenly in the midst of doing your ventilation, you would notice that the patient deteriorates. So just to give an approximate number, in the last 350 patients we're looking at, we have 20 barotraumas. So we have roughly 5% incidence. And then when you look into it, it's either, first of all, seems to be peculiar to COVID itself. Something about COVID seems to be giving more barotrauma, and postulates have been there that is it because of thrombotic tendencies, they have small pulmonary infarcts which give way and so on and so forth. This is for the naive COVIDs who've not been given positive pressure ventilation. The second is the fact that we're using tons of positive pressure ventilation like never used before. Even HFNC, NIV, though we've been following all the guidelines for PEEP and so on and so forth, these people are tachypnic. They alternate between the machine and then eating and then so on and so forth. And there's many fancy theories of what's called patient self-induced lung injury, PCLI, which has come out. Bottom line, there's a lot of fluctuation of the transthoracic pressure, which either in a naive COVID lung or in a weak lung, which we can't figure out, we can't do scans, can cause barotrauma. The third is the mechanical ventilator itself. Certainly strategies have been talked about with different compliances. So depending on that, it's not a cookie cutter model. One size doesn't fit all. And lastly, we're using all these steroids, which we thought were such lovely agents, also going to weaken the lung somewhere or the other. So patient who gets COVID, gets steroids, gets infection, gets tocilizumab, certainly has a lung which is more, and is a substrate for barotrauma. So all these and more reasons have been postulated. Certainly it is a very valid observation, and all we can do is cut the steroids to the minimum, use ventilator strategies which are friendly, use non-invasive strategies which are friendly, and keep a keen eye of observation, because it really takes their course down.
Can I just add to that? Can I just add one? So we just have a doctor who's come back to us who had severe COVID, was managed on non-invasive ventilation, went home, got better, came back for his 4-week follow-up, had saturations of 97, 98% in room air, no previous airways disease. And then 2 weeks later, comes back with 1 day of fever and acute interstitial pneumonia-like pattern and has a spontaneous pneumomediastinum. So all that he was on was reducing dose of steroids, which he was off before he came in. And as you rightly mentioned, we've also seen they're all right-sided pneumothoraces when we're getting them.
Okay. All right. Next question is, what is the significance of lymphopenia? Can it be considered predictor of mortality? I think that's quite well established. Any comments from anyone? Any of the speakers?
Well, one of the things with lymphopenia is that there is a trend that you will see that when the patient gets the lymphopenia and the patient gets admitted, often the ones that we see that gets critically ill and get admitted to ICU, there is a group of 2 or 3 that you can differentiate. The ones that are particularly will do worse are the ones which have a persistent lymphopenia. They certainly agree that then gets into a very hyperimmune state. So you get lots of white cells and lots of lymphocytes going up. That group tends to get better. So a trend of lymphopenia after critical illness is a better predictor. But of course, lymphopenia by itself makes you to have a worse outcome than without lymphopenia.
Okay, while you're there, Dr. Paramasivan, you can take the next one. Because of all this, these antivirals which are being tried for COVID, is there any advance in other viral infections? Is that so-called silver lining in terms of COVID?
Well, the one thing that have opened up the world of antivirals with coronavirus, the one good thing that has come out of it is that the number of people we are looking at the intracellular mechanisms of how the virus replicates, which is very unique, even though we have known it for a number of years. What is happening now is that there is a significant, almost an explosion of how we can manipulate the transcription of these viruses inside the cells. Now, the number of things that we can do to interfere with that is so exponentially gone up. At the moment, there are like 332 trials, all of which being in vitro trials that are currently conducted, looking at various manipulations of these transcription pathways. And we are understanding a lot more about how these viruses behave once they get lyophilized. Because the crucial part of it is, once the virus gets into the cytoplasm, what makes the cell to replicate the virus is almost very crucial, more than how it is presented through the MHC and the antigen presenting cell. So this process of what the virus does inside the cell, I think it's just unraveling. So I'm sure there will be more advances in terms of antivirals as we go along, not only for COVID, but there will be more for the other viruses as well.
Okay, a few questions for Dr. Sanjay Agarwal on remdesivir. Do you recommend using it in patients with cirrhosis?
Yeah, so I have had a couple of patients with cirrhosis, extensive liver disease. As long as I would say that you want to tread very carefully with that. As long as the amino ALT, AST, alkaline phosphatase, bilirubin levels are less than 2 or 3 times normal, and you want to watch the numbers daily, as I mentioned before. Close monitoring, yes, I would recommend continuing remdesivir, but be very careful.
One questioner asks, is remdesivir reserved for those requiring oxygen or for all patients with COVID?
All patients with COVID now as of August 28th. So all patients of COVID can be considered, not necessarily only for 94% and less.
Okay, thoughts about remdesivir for outpatients?
I would strongly recommend against using it. Number one, it's only IV based. So, and it has to be, since it has potential of causing anaphylactic reactions, causing hypersensitivity, as well as for daily monitoring of labs, as well as monitoring of parameters, I would strongly recommend using it only in monitoring settings, not in outpatient setting at all. Unless we have the inhalation form of remdesivir coming out. Gilead is working on that presentation, maybe in future, but not now.
Okay. There's a question on methylene blue for prevention of infection and prevention of pulmonary fibrosis. Any of the speakers want to comment on this? Any of you seen anything in the literature?
No experience.
No? I can't see anybody nodding their heads positively.
There has been some isolated reports about methylene blue being given as an IV form and inhalant form, but I am not aware of any positive data out of that.
Okay. Only circumstances where we have used methylene blue is in those patients where we are severely hypoxic. It is like nitric oxide. It does produce vasodilation. You could have an improvement in hypoxia. Other than that, I don't have any experience of using methylene blue in any other.
Okay, what is the role of ivermectin for COVID?
Well, I did. When I started this presentation, I did have a slide about ivermectin, and ivermectin is actually, the first line to say is ivermectin, surprisingly, is in the national guidelines for period. Now, this is a drug which is a drug that is used for river blindness. It's an antiprotozoal drug, It has, there's been published evidence that it has antiviral effect. In vitro, it does suppress the SARS-CoV-2 virus. The problem with ivermectin is that the dose that is needed to produce enough in vitro concentration is about 10 times of what we would give for a river blindness. So yes, it is a drug that is being investigational, but the dosage that you're going to need would be such a high dose to achieve the concentration that, the safety profile of it is not yet being published in any study that I can see.
Okay, I'll hand over to Dr. Sunita. Sunita, are you there? Do you want to take the remaining questions?
Sure, Ram, thank you. Couple of questions that are there. One of them asked, we are finding high incidence of myocarditis. What are the factors leading to myocarditis? Any of the speakers want to take this question?
Well, I suppose myocarditis indirectly, we see a lot of patients who do have troponins that are high. So having a high cardiac enzyme, either to CK or troponin, is an indicator of a moderate disease. When you then look back on the beta natriuretic peptide, or you look at the echocardiographic findings of the actual systolic motion with the amount of physiological abnormalities, surprisingly, not many of them end up with either cardiogenic shock or a severe left ventricular function problem. We often see the problems with coagulopathy, right ventricular problems, hypoxia. So even though, yes, it produces myocarditis, yes, it produces cardiac enzymes to go up, but by itself, left ventricular dysfunction is not something that we see very significantly.
Thank you. Thank you, Dr. The next question is for Dr. Sonal Pannu. How important is it to match grouping and cross-matching in plasma therapy? Is Dr. Sonal there? If not, someone else wants to take this question.
I'm there, I just was not able to unmute myself. So yes, grouping and cross-matching both have to be done. Actually, typing is more important. In some patients who are AB groups and we have very scarce plasma to give them, in trials and occasionally we are able to give uncross-matched plasma to them. So typing, yes, very important. Cross-matching, I think in rare cases you can give uncross-matched as well.
Okay. Dr. Sonal, one more question. ICMR rejected the plasma therapy based on the PLACID trial. Do you have any comments on that?
Well, yes, I guess that plasma is still not, the holy grail showing that it absolutely reduces mortality, and it can be the one drug which does. I think that in cases where you need adjunct therapies, or you can have this inexpensive therapy to be used, it can help if you get high titers and in early patients. I think the trials were still not well designed at that point to identify the titers.
This question is for anyone who can take this. Please highlight on role of oral anticoagulant prophylaxis post-discharge and how long?
I don't recommend after discharge anticoagulation therapy at all. I don't know about other panel members.
I would like to hear from other panel members. There seems to be a little bit of a difference of practice patterns, at least in this area.
So in our hospital, in our hospital, we have people who've had high D-dimers and who've had more severe disease. We do prescribe them oral anticoagulants, Elixir, apixaban 2.5 milligrams BD for 28 days, and do a echocardiogram when they come up for their 4-week appointment.
Same practice here in the Midwest in the US, at least at Ohio State. We do just as Dr. Chaudhary mentioned, low dose Eliquis for patients who have high D-dimers to begin with, and other prothrombotic issues for 30 days post discharge.
Well, I can tell you in UK, we do it for patients who have definite evidence of any form of embolic disease, whether it is thromboembolism, whether it's ischemia of the legs, or having had a stroke, any form of proven embolic episode, we send them on oral anticoagulation home. And those patients who have been intubated for more than 28 days, we send them home on oral anticoagulation. And we bring them back about 3 to 4 weeks, at which point we get an echocardiogram to look at the right ventricular function. And we normally recommend in those patients with proven thrombus for a coagulation of up to 3 months.
Thank you. There's another question on IL-6. Should we measure IL-6 levels mandatorily prior to starting anti-IL-6 MABs? Does administration solely depend on levels?
So, there's a lot of thing about it. If the patient shows evidence then of cytokine storm, then give IL-6 itself. But our practice is that IL-6 levels above 60 is what we look at. And again, as much as we did use it before, now we are, thinking quite a few times before giving it because of secondary infections post tocilizumab that we are seeing in a lot of patients is there. So we are justifying our use of tocilizumab, and we are taking a cutoff of 60 in patients before we give it. And we definitely procalcitonin because we are seeing very high IL-6 values in patients who have infection as well. So procalcitonin is mandatorily checked with IL-6 before giving.
Sunita, the last couple of questions, please.
Yes. Quickly, 2 or 3 more questions. Can anybody elaborate on the use of antihistamines like cyproheptadine or rupepatidine in COVID?
We don't use it.
Okay. I don't use it either. Okay, fine. Next question is, a few patients present with morbid loss of appetite alone with pulmonary or constitutional symptoms with RT-PCR positive. Any suggestions how to manage with this where they do not have pulmonary symptoms, but it's more of a systemic constitutional symptoms? Any speaker wants to take that? Constitutional symptoms? Okay. What I do in my practice is if they're very sick, then we at least sometimes give them steroids to help them recover, and that seems to be working. I'll move on to the next question. Last question for Dr. Sushmita Agarwal regarding the use of, in patients with iatrogenic this is my question. Patients with iatrogenic immunocompromised state, either be it rheumatological conditions or a transplant recipients where they're already on immunosuppression, mycophenolate, tacrolimus, how do you manage the immunosuppression on these patients?
Did you ask me?
Yeah.
Okay. How do you manage? We stop the mycophenolate for sure. Tacrolimus, again, depending upon if they're renal recipients, then we definitely think about whether it should be continued or not. In lots of patients, we don't stop it, but we keep a very close eye on with broad spectrum.
And the last question here, what are the chances of recurrence after treating with plasma therapy and remdesivir? And what are the complications and the prevention for a patient who recently recovered from COVID? Dr. Paramasivam, want to take that?
The ones that we're giving the plasma therapy, we in UK only give it as part of a clinical trial. And I have to say, I haven't got lots of experience of following up these people to give what would be the most effective. The ones that we have, in Leeds, we have given plasma therapy for about 10 patients so far. So we only had about 300 patients in total. So in UK, it's probably about a couple of hundred patients who have had it. So it would be unknown at the moment. I don't think I can give you too much guidance on that.
Dr. Sonal, you have a comment?
Well, about the current question, we have a lot of our patients who follow up. We haven't seen, I don't think there's a specific recurrence associated because of plasma therapy. If they have any complications with it, that will happen Reinfections, at least in this area, have been very, very rare. And as you have seen, even out in the data, there's a few cases of reinfections in the world right now. I do see that when people are donating plasma, over the weeks, we have the same people who come and donate, and their titers do start falling. So we have the potential 4 months of staying of antibodies, and there's a possibility that these titers keep falling later and later. I just had one comment when you had talked about IL-6, and we would use IL-6 before, but we can see very clearly now that we are using dexamethasone even in patients hospitalized, not ICU. IL-6 levels just are no longer relevant because they already get depressed before, and then you can't follow them really.
Well, thanks ever so much, Sunita and Ram. Thanks a lot to our faculty and colleagues from 20 countries who joined and who've stuck on till the very end. This has been absolutely fascinating. Perhaps never have we seen such a huge change in what we believed would work, and then actually do so many U-turns as time has gone by. And I think when we do this again in 6 weeks, I don't know what we'll be talking about in terms of definite therapy. But thanks ever so much. We look forward to interacting with you again, and we will be back soon with another session. Thanks so much. Bye-bye.
Everybody.